So we have a 75-year-old man who is also a physician. So he presents to Dr. Cohen for a few weeks of vision changes in the right eye. He noticed that cars looked like they had a flat tire when he was driving, and lines looked distorted. And
Actually, Nissan, are you dialed in?
Yeah, he's in the operating room.
Okay, his picture's there. Hello? Okay, yes.
You might be scrubbed in just listening.
Okay, all right. Keep doing surgery. Don't. Stay focused. I was doing surgery a couple months ago on this lady, and I had the diathermy in my hand, and I thought it was the light pipe. I don't know, it was just the diathermy. So I was like, the light's not working. They said, what's plugged in? I said, well, switch it. And then they switched it. And I said, and I looked at my hand and said, oh, I said, this is the diathermy. I said, I guess I'm just being spacey. And the patient goes, don't be spacey. So I gave her some sedative. Yeah. It's like there was so much I'm blanking on, but not, yeah, we don't need to remember this thing. All right, Madeline, go ahead. It's your turn. Okay.
So yeah, a few weeks of those right eye changes, no changes in the left eye. Medical history is positive for hypertension, hyperlipidemia, thyroid disease, and then surgical history, just had spinal surgery in 2017. Some of the medications that he was on, so Crestor, let's see, a bunch of supplementations, CoQ10, vitamin C, aspirin, vitamin D3, B12, and then Synthroid. Vision was not too bad, so 2025 +1, and then 2016 -1, not corrected. Pretty good, right? And then pressures are 21 and 22. So,
I don't have a color because I didn't expect this to be interesting, so.
All right, so we have bilateral IR photos. It looks like attention is drawn to the right eye. In the fovea or parafovea area, there's some hyperreflectance, and then just a very dark foveal reflex in the right eye. And then perhaps a little bit more nasally, there's some hyperreflectant, more subtle lesions there.
yeah.
Thanks.
And then maybe a
little bit
couple
in the
here on
left
the left eye. Yeah, awesome.
This is autofluorescence.
Okay, so we have autofluorescence of both eyes again, and then attention is drawn again to that foveal area. There's some hyperautofluorescence with some bordering signal voids or blockage next to it. And then possibly some like reticular patterns surrounding all of that. And then in the left eye, there's maybe a little bit of modeling as well, just in the perifoveal area.
Yeah, and then maybe this is a little area of hyper autofluorescence there. This OCT, the right eye.
There's an OCT of the right eye. Looking at the cross section, it looks like there's some pigment epithelial detachments, and then with some overlying intraretinal hyperreflective lesions, I guess.
Nice.
So I'm gonna scroll through here. We can start appreciating some changes here.
So what do you see on that cut?
It looks like there's a dark lesion in the internuclear layer without shadowing. And that looks like it corresponds to one of those hyperreflective spots in the IR.
So would you just call it intraretinal fluid at this point?
Yeah, it's a sort of fluid. It's funny looking fluid. It might be a little hemorrhagic. There was a dark, sorry, the autofluorescence had some darkness, which might be blood. So there might be, but it's probably fluid and a little bit of blood.
And then so some outer retinal disruption here above those PEDs.
So this one's a high res. Sorry, this is a high resolution scan here. So what do you see? I mean, if you look at the other eye first, look at the left eye. So what do you see there?
So the left eye, there's some more subtle PEDs, and then maybe some disruption of like the inner plexiform even, or
Yeah, the outer
some
retina looks
accumulations in
pretty
there.
good. Yeah, if you look at the different layers, the left side zone or and even the external limiting membrane, you can kind of see them contiguously. Those are large drusins, so you can call them PEDs, but they're really just big drusins.
Help us differentiate.
Large,
I've heard so many different things. How
I
do you
think-
distinguish PED versus?
Just like drusinoid PED.
I'd say drusen, but so for a drusen, I think they're uniform. They're like, what's that, probably 200 microns across, they're not 500 microns. But for a PED, if it's like a serous PED, it'd be dark. If it was a fibrovascular PED, it would be hyperreflective. So the drusenoid PED, and you can kind of see the Brooks membrane, I'm blanking on from the choriocapillaris, what are the layers of Brooks membrane? You've got your but then what's the other one on the outside? The basement membrane. Yeah, so you can see the basement membrane of the choriocapillaris there, part of this sort of splitting Brooks membrane.
Super, thank you.
So but then the other eye, so then going back to the other eye doesn't look as good, does it? So what do you see there? There's a couple findings.
There's some large drusenoid PEDs, and then with some overlying disruption of the inner and middle retinal layers.
And I would
There's
call
some
that
fluid.
fluid. I mean, that's dark. And then you can even see subretinal. I mean, if you look into the fovea here, I mean, they should be snug. So all those layers should just be right on top of each other. And if they split, that means there's fluid there, or blood. So you got your RPE there, and then you're splitting off the rest of the layers. So there's a little bit of fluid here and a little fluid there overlying a PED. So that's probably something going on there. And the patient has new symptoms of distortion in the right eye.
All right, awesome job. So talked about the left eye, some similar changes, but maybe not quite as severe. And then this is the FA of the right eye. There's quite a bit of pictures, so I'm going to scroll through them, but just pay attention to the time for this one. It's also relevant.
Delayed filling.
Yeah. So we're at 53 seconds and then the choroid's finally starting to light up.
You just have really long arms.
Yeah. So yeah, correct, delayed choroidal filling time. And then anything else that you can appreciate at this point?
I guess there's signal void in the fovea.
You call that hypofluorescence
Awesome.
for fluorescein.
And maybe an area
A little bit of hyper.
So what are your two causes of hypofluorescence? There's only two.
Blocking in a signal void.
You're blocking and non-perfusion. So which do you think that is?
Non-perfusion. Or no, blocking.
Probably
There's fluid. Yeah.
Yeah, you can sort of see a vessel almost going under it. It almost looks like it's obscuring a vessel. That's why I've had a color picture. So that's blood. I just don't have a color picture.
Okay, so we're at 6 minutes there. And then what would you call this area here?
So you think that's
Leak.
leaking, pooling, staining.
I would say leaking.
It's leaking, but it does look like it's leaking some into a fluid space. So it's also probably leaking.
Pooling.
A little challenging. That's probably kind of classic.
That's an RPED.
Yeah,
Go back,
I think that's the
Go
intraretinal
back,
fluid.
go back, keep going. No, go forward. Forward, keep going. There. You got hot cross buttons. I'm from Boston. We love hot cross buns.
Right.
That sugar on the top, and a hot cross bun is delicious, and the raisins, oh, I love them. There's a reason I
So
have heart
Pete,
disease.
all right.
But see that dark lines, a little B there?
Yeah.
That's a pigment line. That's a classic, a little small, but almost classic. RPED. It's filling.
Yeah.
So it's pooling?
Yes, it's pooling into there. So
It is.
it kind of leaks, it leaks into a fluid space.
Good job. This is the left eye. We don't have the earlier phases, but I think they were unremarkable.
Yeah, I don't think,
Left
by
eye.
the time we don't shoot the other eye till later.
What time is this at now?
This is a minute 37.
Oh,
This is 6 minutes.
What are those spots that laid out?
That's staining.
Yeah, and what's the, okay, do you know what it corresponds to probably? Anatomically,
So
I'm not sure.
it's the drusen.
yeah, I think it's just the drusen filling.
So
Why is it- can I ask a question? Why is it that for drusen it's staining, but for PEDs it's pooling?
Staining's fluid, staining's building of fluorescein into a solid space. And pooling or leak pooling is,
That's an oxymoron.
it's from the, no, it's more into a solid.
Solid.
That's what it says in the book. If you
I
look,
know, it's-
I've read it a million times. So if you read your book, it says staining's where you get fluorescein building up into a solid space. And pooling's where you get fluorescein building up into a fluid space. And drusen are solid enough, I think.
So even if you had like a fibrovascular PED, would it still pool or would it?
That would be staining, unless there's, like on the OCT, you would look, on OCT, you see like a dark area that's fluid. And that fills, then that would be pooling, but if on the OCT, you see like a non-dark area.
Okay, my definition of cooling,
Go ahead.
okay, is as the fluorescein progress,
Right,
you have a very ill-defined edge and it gets bigger and bigger and bigger and more intense. If you have a the drusenoid.
Yeah.
That RPED with the hot cross buns, that edge is sharp.
right.
It is very sharp in an RPDE. It's filling the RPED. I don't call it pooling. I'm not sure what I call it, but the edge, because the edge is sharp and because it doesn't expand, I do not call it pooling.
Okay.
But it could still be a vascular event under that RPED, which we, until OCTA, we couldn't really study. There was no good way.
Well, the drusen fill, I mean, somebody got this wrong once. Do you know where the blood retinal barriers are? Yeah, the RP. So if you look at your drusen, their RPs above them.
Yeah.
So they've got free access to the choriocapillaris. So the fluorescein is going to go into those.
Yeah.
And so that's good. Jeff, somebody didn't know that years ago. Almost gave me a heart attack. We were. All right, good. Didn't know the blood retinal barriers.
So, summarizing the findings, I think we pretty much hit them all there. So any differential diagnoses, there's two actually diagnoses for this patient. So one addressing all the findings on the imaging, and then the other one is addressing the delayed choroidal filling. Correct, yeah, so any like carotid artery disease can make you think for the delayed choroidal filling.
There's another big
Anything
one.
else?
If you're gonna work up delayed choroidal filling, because it's published and probably legally, you should know it. So you got somebody over 70 with delayed choroidal, not actually, I wouldn't call it delayed choroidal filling. I call it, what I do is arm to eye time. So you got arm to eye time and then you have recirculation. So if you have a slow arm to eye time, there might be a blockage somewhere. It's giant cellulitis. So there's been, I think, enough publications on giant cellulitis that it's something you kind of need to know.
so it's just an ocular ischemic.
Yeah, sort of.
And then any other differentials for all the other findings that we saw? Great.
Great.
Yeah, so like age-related macular degeneration, pigment epithelial detachment, maybe like a retinal dystrophy, like something like Stargardt's, pattern dystrophy.
Yeah, awesome. So For the differential, like we mentioned, for that first part, giant cell should be on the top of the differential. Carotid insufficiency, and then hyperviscosity syndromes can also be considered.
Can heart failure also? It would be bilateral, like it wouldn't be so asymmetric.
Girl harm tide.
Uh-huh. Like you're just heart not pumping enough.
I don't know if it would.
Well,
It would
it's
be
actually-
so slow.
And it would be equal, like this was like 9
Well,
minutes.
no,
and,
No,
like,
'cause
oh, no, you can't check both eyes. You only get your fill on one eye.
We also
always be
inject it to a vein,
But,
right? So it's the venous traveling.
so it's vein, well, it goes vein to artery to, I guess,
then-
I guess it probably
Oh.
would.
It has to go through the.
Yeah,
Cause it would be like a venous stasis.
Right.
You're just not pushing from.
You know, when you think of the path, it's a fairly good distance. Yeah, I guess that it probably would mark it up.
It'd be delayed filling in both eyes. Though.
Yeah, but you can only get filling in one, of course.
We don't know if the other one.
Yeah, you don't know the other, because
So
you
you
don't
should, wasn't it 1 minute? on
but
the
you,
other
but
eye?
you shoot one eye.
Oh, I thought you had a picture of the other one that was 1 minute.
Right, but you can't, when you do the fill, you can only do the fill on one eye, unless you have two cameras.
Well, the one wasn't filled by 9, it just started filled by 9 minutes, and at one, it was already filled. You know what I'm
You
saying?
can only get filling. You
Okay.
can only get the fill in one eye, because you're shooting, and the fluorescein hits the eye, you can only tell in one eye. You'd have to have two cameras to do two fills.
No, I know, but like the one hadn't even filled by 9, and this one, you don't know exactly when it was filled, but you know it was filled by at least 1 minute.
Right.
This one, it took like 9 minutes to even.
Oh,
start
no,
to
the
fill.
first one filled in like 40 seconds.
Oh, okay, never mind.
yeah, it's like 56 seconds.
I thought it was not.
It's good you're so far away.
Awesome. So this patient had actually carotid insufficiency and then wet macular degeneration. So awesome job, Grant. So a little bit more history. Patient returned after several anti-VEGF treatments with improved vision, and then also had a carotid endarterectomy on that right side. So Dr. Cohen had recommended that he gets a workup for it. Ended up having surgery. So he, on one of his return visits, he requested a follow-up FA. And then his vision improved to 2020 and 2016. And then the following pictures are from 5 months after the initial visit.
I didn't think it was ethical to get one just for teaching, but the patient asked for one, and I said, I'd love one. So he said, okay, I said, we'll use it for conference.
So the right eye here, just kind of scrolling through it. So the foveal contour is intact, and then the intraretinal fluid cyst that was there before looks like it's resolved. You still have the outer retinal disruption there, but not as,
2016
yeah,
That's good.
pretty good.
Yeah.
for any age.
And then this is the FA. So it looks like we have a little bit more choroidal filling there at like 21 seconds, 22 seconds rather than the 50, 55, 56.
Is this after like a carotid
He joined that first visit with an endarterectomy. So very thankful that we had checked for the carotids. He's a doctor.
And then here, don't appreciate as much leakage at 4:45.
What's that? Like, right circle. That's where the initial lesion probably was, the PED and the neovascular membrane.
So definitely much improved. And then here the left eye looked pretty stable. So this part's brief, but I just wanted to review kind of the stages of an FA. Dr. Cohen did a great job teaching us in the beginning of the year, but just for the sake of the PGY ones and a nice review. So arm to choroidal time, usually about 12 to 14 seconds, and that's supplied by the short posterior ciliary arteries.
Wow, this is nice.
Then the choroidal to arterial time, it's usually a few seconds after that, so around 13 to 17 seconds.
Is it 13 to 17 total? or
Total.
Since.
Correct, yeah, so
It's 1 second between those two. That's what I was taught.
Yeah.
Between the choroid and the arterial.
Yeah.
You can't rely on the counter on the cameras because you don't know when they start.
Well, that's why I showed this case to my
Yeah.
partners, and most of my partners would not have gotten a carotid study. Because a lot of people don't trust the timer. I trust the timer, plus I do a lot of my own pushes.
Well, there you
So-
are. I mean, it's.
So I push it in, so I know it's right when I hit the timer. The other thing is to have a delay on the timer means they hit the timer before you even checked it, which would be weird. Typically, they would hit the timer, like they'd start shooting, get confused, like, oh, I gotta hit the timer, which would make it seem shorter. You don't want to
So, yeah, choroidal arterial time, few seconds after, like about 1 to 3 seconds is what I saw. And that's supplied by the retinal arteries. Your next stage is the arteriovenous phase, and that's also a few seconds after. That's where you get both your arteries and veins, and that's where you appreciate the laminar phase. Then next is the venous, and that's what I read was the cutoff is usually around 30 seconds is when you want to start seeing just the venous phase. And then the recirculation is anywhere from 30 seconds to 10 minutes, and that's where you diagnose your pathology.
So I was always taught it's choroid to arterial, 1 second, arterial to some filling of the venous is 1 second. But we often show a picture saying it's arterial phase, but if you look very close to the disc, you will see a tiny bit of laminar flow. And we ignore it, and we say this is the arterial phase. With the current cameras, because they take multiple pictures per second.
You can video,
Yeah, I mean, you can probably get better data, but with a fluorescein camera, it was the fastest you could shoot them was 1 second. So that's what we.
Yeah,
ended up with.
flash that to recharge.
They use huge capacitors to generate charge to do the flash. How many of you have had a color fundus photograph taken of yourself?
Mhm.
I was amazed because I had a ton of blind you.
It's so.
It's very good.
It is.
The rest is brutal.
Is that why you consider it not necessarily ethical to get the repeat?
Oh, fluorescein, well, because you're sticking something into their arm.
There's a risk.
Yeah, there's a risk.
And life, that's other things.
Yeah, I mean, it's totally unnecessary, but I was like excited, I was like, I'd love to, and he's like, yeah, he wanted to see it, I was like, you're patient, do whatever you want. So he wanted to see it, so we got it, so I think it might be right upable. Heidi and I are gonna see if we can find a place to put it, I think it's an interesting case.
So this is the choroidal phase, this is a patchy one. And then this is here, the arterial phase, you can just appreciate the arteries filling. Then this is the laminar phase, so this is where you see the dye being pushed out to the sides of the vessel.
Notice in the picture on the right, out on the periphery, there's less laminar than there is closer to the disc. Because that, you get, it's a shorter distance.
Mm.
So you get quicker filling of the vein.
And then this is the venous phase, and this is the brightest typically. So, the things you want to think about when you see delayed choroidal filling time, of course, carotid artery disease, so any narrowing or blockage of the carotid arteries. Then ocular ischemic syndrome, which is specifically reduced blood flow getting to the eye, and a number of things can cause that. And then I thought this was interesting, but CNV can actually cause delayed choroidal filling time. Because it can alter blood flow dynamics and cause delayed filling. So I guess it might be just like the vessel like steel syndrome.
And would that be like, just like a few seconds, or not, it wouldn't be gross? like-
Very short.
I would guess.
I don't buy that.
I guess what a theoretical thing, it's like, yeah, play against you.
Like a steel syndrome.
I
or
don't
something.
buy, I mean, so you're gonna have to have a big vascular scar.
Yeah,
I don't buy it.
and then choroidal tumors can also affect blood flow. Inflammatory conditions, you definitely want to think about that, such as giant cell, and then retinal vascular diseases like a vein occlusion or diabetic retinopathy can also affect choroidal filling time. And the big one that our patient had, of course, carotid insufficiency. So the risk factors are the same for your vasculopath. So hypertension, hyperlipidemia, older age, any history of cardiac stents or strokes. And then the clinical presentation for these patients, it's a spectrum, so they can be asymptomatic like our patient, then transient ischemic attack like amaurosis, and then ultimately a stroke. So diagnosis for these patients and the workup you want to get for them is a carotid ultrasound, plus or minus an MRA CTA. I found this cool chart of when you would choose, well, we wouldn't choose to operate, but when a vascular surgeon would. So I hope we're not. And so non-severe would be 50 to 69% blockage. So it then further breaks down if whether they're symptomatic or not. So if they're asymptomatic, you just observe and just mitigate risk
That's where I am,
factors.
left side,
Right here.
wait for my surgery.
At least you don't have ladder. Generation.
Well, I don't know. I might.
And then if a patient's symptomatic, I didn't know this, but I guess it's dependent on the specific surgeon's rate of death or stroke rate for patients.
I remember early in the days of carotid endarterectomy, this was a big deal. I think now it's not as bad. But it used to be the stroke rates were pretty high. But now,
Yeah, that's-
you know, and so you wouldn't do it. Now I think they're a lot better. I mean, there's even talk about filtering, bypassing and filtering and all sorts of cool things you can do, but yeah, the stroke risk is high. Is this, you know, is this kind of new or older?
Yeah, well, it was like 2018.
Okay.
so-
There aren't any recent studies.
Yeah, I remember the
Yeah.
VA, there was an old VA study that really stopped people in their tracks when carotid were started. The
You
VA
got- you
study
got-
had a huge
Unlike the
stroke
heart,
risk.
you actually have a collateral circle of Willis, so many times patients will come in.
Mhm.
And one of the arteries will be occluded, and they're doing fine.
Right.
The problem is the patients where they didn't do fine with one occluded artery, they're not walking into your office, so.
Yeah.
It's kind of a skewed.
So pretty fine margins there, has to be less than 6% of death or stroke rate, and then you would consider under endarterectomy or stenting. And then if it's severe, so it's about 60 to 70
Blue, 1/8 blood draw.
to,
So blue. That's fine. Blood draw.
They want one blood.
Too
much.
so 60 to 70%, all the way to 99%. Further breaks down if they're asymptomatic. And then I thought this was pretty ambiguous, but are they at high risk for stroke? If no, then just watch them.
Ample blue. One hotel. Ample code blue. A blood draw, one hotel.
Make the diagnosis just sitting here.
And then if there is a high risk for stroke, then it has to be less than 3%. And then death or stroke rate for that surgeon, and then you'd consider the endarterectomy. If they're symptomatic, we're back to less than 6%. Then if it is, then you do the procedure.
It depends on the surgeon.
Depends on the surgeon. So briefly on ocular ischemic syndrome. So this is ocular hyperperfusion, could be embolic or stenosis or an occlusion. Males are affected twice as much as females. There's 22% of cases that end up having bilateral involvement. And then I thought this was interesting, but the most characteristic findings are delayed choroidal filling time. That's the most specific FA sign. And then prolonged AV transit time is the most sensitive FA sign, which is interesting. And the patients with OIS, similar to carotid insufficiency, could be asymptomatic. They may report multiple non-specific ocular symptoms, and this makes the diagnosis relatively challenging, especially in patients with comorbid ocular disease like our patient. And then there was a study that showed that 42 patients with ocular ischemic syndrome, about 35 of them had more than 2 ocular symptoms, and it included visual loss, ocular periorbital pain, amaurosis, photophobia, floaters, metamorphopsia, and diplopia. And I actually have a chart here that I found that kind of highlights all the signs of ocular ischemic syndrome, which I didn't realize was so extensive. All these things are really non-specific, so you just have to have a high clinical suspicion for ocular ischemic syndrome, because it's one of those things you don't want to miss.